thank you all for having us here today because it is just so lovely to get to talk about the workforce today. And for today's talk, I'll be talking about the oral health workforce in North Carolina, how the supply is improving, but distribution and diversity remain challenges. And as Steve said, I am from the UNC Cecil G. Shep Center for Health Services Research and a part of the program on health workforce research and policy, led by Dr. Aaron Frere and Dr. Brianna Lombardi. And today, in case you don't know who we are and what we do at the Shep Center, we lead the North Carolina Health Professions Data System, what we call the HPDS, where our mission is to provide timely, objective data and analysis to inform health workforce policy in North Carolina and the United States. We're based in the Cecil G. Shep Center for Health Services Research at Chapel Hill, but our mission is statewide. And it's really a collaboration between the Shep Center, the North Carolina AHEC, and the health professions licensing boards. And importantly, our system is independent of government and healthcare professionals. So while we are housed at UNC, we really make sure that our work is objective and data driven. And of course, our health professions data system would not be possible without the collaborations that I just mentioned, which include 43 years of continuous and complete licensure, not survey data, licensure data, on 21 health professions from 11 boards. And these data have been provided voluntarily since that time. I'm going to stress that again just because it is such a unique relationship of a data set and database as large as this, that the data are provided voluntarily. There's no legislation that requires this, and there's no appropriation. The data is housed at SHEPS, but they remain the property of the licensing board. So any new data requests or any work that is done with them, permission is sought by the boards for that new use. And of course, this system would not exist without the data and the support of those licensure boards. And we are so grateful for that. For example, the data that I'll be presenting today comes from the North Carolina State Board of Dental Examiners. And on that topic, let's dive into the dental workforce in North Carolina. So if we take a look over time from 2001 to 2022, North Carolina has gained dentists per capita, although it's still below the national average. Dentists working in dentistry per 10,000 population has increased in the United States from 5.7 to 6.1 in 2022. And if you take a look at North Carolina's rate, you'll see that it's increased from 4.2 in 2001 to 5.6 in 2022, which means our rank in terms of all the other states has gone from 47th in the country to 24th. So we've really been increasing our dentists per capita, though it's still below the national average. And what I want to show you here is that same rate and rank change over time. So what I want you to focus in here is on the blue line over time. That's us, North Carolina, going from 47th to 24th in 2022. But if you compare that to the other southern states as defined by the US Census, you'll see that we've had quite the growth compared to those other states over time. In terms of where we receive most of our dentists from, we import the most dentists from Florida, Pennsylvania, South Carolina, Virginia, and New York. This is data from the Health Policy Institute and in conjunction with the American Dental Association. You'll see that 31 dentists come from Florida, 27 from Pennsylvania, and so on for the other states. But then who do we send our dentists to? We export the most dentists to South Carolina, Florida, Virginia, Georgia, and Ohio. And you'll notice if I go back to importing, you'll notice that South Carolina, Virginia, and Florida make both lists. And in fact, South Carolina, we seem to share quite a bit of dentists because the import and export rate is exactly the same at 23. And if we think about the actual net gain of dentists. This is a figure that can also be found for the Health Policy Institute and in conjunction with ADA. Typically, this figure is actually more vertical. I split it across so that it would fit nicely for the slides. You'll see in the green that these are the states that are gaining more dentists than they are exporting, according to that data. And for North Carolina, our net gain is 5.5%, whereas the states in the red are losing more dentists than they are importing. But then let's think about where these dentists who have been coming into the state have gone. And I know that there's a lot on this slide, so I'll take you through it. In terms of where dentists went between 2017 and 2021, 60% went to 5 counties. So we looked at the new dentists who were added between 2017 and 2021, and 60% went to Durham, Guilford, Mecklenburg, Pitt, and Wake counties. 351 new dentists. Whereas another 119 dentists came from or went into Brunswick, Moore, New Hanover, Orange, and Union counties, whereas the remaining 90 counties only gained 20% of the new dentists of 116. Yet if you look at the bottom row here of the 31% of the current population in the state, those 90 counties represent 61% of the total North Carolina population. But this middle bar here is also interesting. If we think about these 10 counties in the dark orange and the light orange, Durham, Guilford, Mecklenburg, Pitt, Wake, Brunswick, Moore, New Hanover, Orange, and Union, those 10 counties accounted for 45% of the ones that gained the most dentists of the new population. So 5 counties added 60% of the new dentists. Those same counties were making up 45% of the population growth in the state. And so the majority of the population growth happened in those 10 counties. They just were not the overall population of the state that we were seeing that growth in. Now, if we think about this growth, let's also think about a snapshot in 2022. If we go one more year ahead, you'll notice that they look very similar in terms of which counties have the most dentists per 10,000 population in 2022, where Orange County in particular is an outlier of 18.6 dentists per 10,000 people. And this might also be because of where dentists are trained. The top 5 dental schools who are contributing to North Carolina's dental workforce in 2022, you have the UNC School of Dentistry in Chapel Hill, who has 2,279 active North Carolina dentists in the workforce in North Carolina in 2022, making up 38.7% of the active dentist workforce in 2022, followed by ECU at 337 dentists. And then these other 3 have changed between last year and this year. But you'll notice that there's the Medical University of South Carolina College of Dental Medicine, New York University, and West Virginia University. These 5 schools making up a majority of the dentist workforce in North Carolina. And you'll notice those schools that aren't the North Carolina schools, except for South Carolina, are not the states that I was mentioning earlier, though I would like you to keep in mind that this is where people were trained, not necessarily where they were coming from in terms of their state immigration and migration. If we delve a little further into the dentist workforce who graduated from UNC School of Dentistry, this map shows you the percentage of dentists who graduated from the University of North Carolina Chapel Hill School of Dentistry, where the darker the color, the more concentrated UNC alumni are. And so you'll notice that there's a large concentration in some of the eastern counties and then more in the central, but not as much in the southwest and in the far west. Also important to note is that the stars on this map represent the non-metropolitan counties. So think of those as the more rural counties as defined by the census, where they're based off of a core-based statistical area, where anything with a star is considered a non-metropolitan, or sometimes we would term that rural county. I wanted you to keep that in mind because if we take a look at the East Carolina graduates who were active in 2022, they are almost 2 times more likely than all other programs to serve in rural areas. And you notice this follows the same format as the previous graph, where the darker the purple, the more concentrated that county has ECU graduates. And so you'll notice out in the eastern counties, there is a higher concentration and it's closer to ECU. But then you also see that there are some counties out in west, or ones that have stars with them, so the non-metropolitan counties, that have more ECU graduates in the active workforce in North Carolina. I point that out to you to show you a different version of the same data, where if we take a look at the percentage of dentists who graduate from East Carolina University School of Medicine, where the darkest purple is that they have 20% or more ECU graduates in that county, you'll notice that the larger the concentration shows up in relation to ECU and its community service learning centers. Where you have ECU and a large concentration of ECU graduates in the active North Carolina dentistry workforce, and then the service learning centers I've marked in these, let's call them magenta circles, and you'll notice that there are ECU graduates serving in those areas as well, but not as much in the middle of the state as compared to, say, the University of North Carolina, Chapel Hill. Now, I said that ECU has more graduates working in non-metropolitan areas. That's actually true for all of the North Carolina-based programs, so ECU and UNC are both more likely to be serving in the non-metropolitan counties than programs where we are seeing dentists from out of state, for example. But then we've talked about training, we've talked about where we are receiving and exporting these dentists. Let's talk about the demographics of this workforce. In the North Carolina population, 69.6% are white or Caucasian. Whereas in dental hygienists and dentists, there's 90.3% and 78% who are white or Caucasian. And so you'll see that the race and ethnicity of the dentist and dental hygienist workforce, it's falling short of matching the population diversity. And this is improved compared to earlier numbers, say in 2014 or 2017. Dentists and dental hygienists have improved in their diversity, though it is still not matching the population. And then if we take a look at active dental hygienists over time, looking from 2000 to 2022, you'll see that the numbers have steadily been increasing. And then in 2020 and 2021, we heard reports of how offices were closing and that it was then difficult to find dental hygienists when things were reopening. And so you see this dip in 2021 and this increase back in 2022. We were curious to see if that would increase in 2023 data. That is yet to be released, as we are still processing the 2023 data, though it seems that it follows with the trend that has existed, where it continues this increase following this trend over time. And one thing that we wanted to harken back to was a program led by the North Carolina Sentinel Survey, where this was a qualitative data that was a program in conjunction with the University of Washington, getting reports from employers about what was happening for their workforce. And so we wanted to share some of the responses here, where one place was suggesting that the practice recovered from the COVID crisis, but was operating reduced efficiency due to all new protocols instituted and reluctance of patients to return to normal. Due to the lack of office staff, the clinical staff is now performing office duties to handle the workload along with their usual duties as clinical staff. And then many of the patients who postponed their visits when they were concerned about COVID are now more comfortable to come back. But unfortunately, we cannot get them on a regular hygiene schedule because we are down on hygienists. We only operate with 2 hygienists generally, so being down 1 is a serious dilemma for us. This was actually something that we were noticing in the qualitative data, that it was mentioning staffing and workforce issues on the broader scale, not just about dentists, but about the rest of the team as well. And so that has been the overview of our dental workforce in North Carolina. And I myself am Connor Sullivan again, and if you have any questions, please feel free to email me at cpsully@unc.edu. Also, please check out the resources that we have available at the Shep Center and on our own website at healthworkforce.unc.edu.
Connor, before you leave, we do have one question in the chat. One
Sure.
of our participants would like to know if the numbers that you presented today reflect the number of licensed dentists or dentists who are actually practicing and providing care versus administration or education.
That's a great question. So these are licensed dentists because this is data received directly from the North Carolina Board of Dental Examiners. And then we do processing on our end to ensure that the person has an active practice in North Carolina. And then we then also can split that out by specialty. So for example, endodontics, the new specialties that we have started tracking of oral facial pain and dental anesthesiology, where they received those new specialties in 2019 and 2020, we can take a look at that.
Thank you very much.
Thank you very much. Any other questions or things for this presentation?
Connor, can you just say a word about the dental HIPSAs in North Carolina?
Sure, absolutely. Here, I'll pull that back up. So in terms of more information, last year, all 100 counties in North Carolina had a dental health profession shortage area, though in terms of June 1st, 2023, 97 North Carolina counties had that designation. And then they also have 188 dental health profession shortage areas as of June 1st. 2.91 million North Carolinians live in those health profession shortage areas, and 22% of the need is met, so the number of dentists available to serve the population of the area. In order to remove that dental health profession shortage area status, you would need to increase the dentists by 578. So achieving a population to dentist ratio of 5,000 to 1 in all designated HIPSAs. In terms of the map from the North Carolina Department of Health and Human Services, the Office of Rural Health, here are the counties with a population or geographical dental HIPSA, and then counties with at least one auto HIPSA facility with the red triangles. All that data is as of June 1st, 2023.
And Connor, I have just a couple more questions. Are
Sure.
these statistics available online at the Shep site?
Yes. So we actually have on the healthworkforce.unc.edu, and also you would be able to find it through the Shep Center as well. We had 2 dental blogs specific to some of this data, but then you can also access our visualization, which has the rates of the dentists and dental hygienists per 10,000 population, the total count. You'll see other demographic factors over time on the North Carolina map. So you can check and see the different things there. What you can also do is, if you're interested or if you have questions about that data, you can download it directly from that website. Or if there's a specific project that people have, we often get people who will reach out to us requesting data. And so that's a piece where you can work with us, and then of course the state board, as I said earlier, if there's something unique that you would like to delve into.
Perfect. And can you define autohipsa, please?
That I'm not as well versed in. I myself deal more with the data side of things, and so the definition is probably best defined from the North Carolina Department of Health and Human Services, or from the designation definitions itself.
Perfect. And then to remove the dental health provider shortage areas, it would also mean that they would have to practice in those areas, correct? Not
Correct.
just increase the number of dentists.
Correct.
Fantastic. And then last question, are there any grants that people can apply for to get assistance for their dental work? I think we may have to answer that one offline.
I believe so.
And that is all I have for you.
Thank you so much.
Thank you, Connor. That was very helpful. As you see, we've got great resources in North Carolina. And so please take advantage of that. Next, we're going to move into the panel presentations and discussion. And I want to introduce our moderator for the day. It is Hugh Tilson. Most of you know Hugh. Hugh is the statewide director of our North Carolina AHEC system, which is widely considered the best AHEC in the country. And we are really delighted to have Hugh with us today. Hugh has been a supporter of the Foundation for Health Leadership and Innovation, as well as the North Carolina Oral Health Collaborative. He serves on our advisory group, and we are proud to call him a friend to oral health in North Carolina. So I will turn it over to you, Hugh.
Well, thank you, Steve. And it's always good to hear you and see you. And I truly value the work that you guys do, and I'm pleased to contribute any way I can to supporting all of that amazing work. So I want to thank you and your team for that, and want to encourage you to keep it up. So thank you for that. I have the privilege of leading this panel of wonderful panelists, and many of whom are friends and colleagues. And so I know you don't really want to hear much about me. You really want to hear directly from our panelists. So I'm going to run through a quick introduction. I'm going to ask each of our panelists to introduce themselves. And then you've seen their bios in the materials. I'm going to ask them to talk about something that's not in their bio, kind of a little fun fact. And then we have, I'm going to turn it over to each of them for a little bit of a conversation about the things that they want to present. And then we should have plenty of time for questions and answers from you guys that are participating in the webinar. So, and I'm Hugh Tilson. I'm the director of the North Carolina AHEC program. My fun fact is that when I was in college at the University of North Carolina at Chapel Hill, I sang in a men's a cappella group called the Clefhangers. And I miss those days of singing and wish I could find time to get back to it. But that's my fun fact. We're going to do these in alphabetical order. So Stephanie, why don't you introduce yourself? And then if you want to, you can ping it to the next person, or if not, just let me know and I'll take it from there.
Thanks, Hugh. My name is Stephanie McGarrett. I'm the director of the Pandemic Recovery Office in the Office of State Budget and Management. So our office was created to help manage the federal funds that are coming to North Carolina for pandemic recovery. My background is in workforce and economic development, and I also worked in the healthcare industry for a good period of time. I am from Western North Carolina. I don't know if you consider that my fun fact, but I also serve on the board of a charter school in Durham. And I'll kick it over to Andy McCracken.
Good morning, everyone. I'm Andy McCracken. I'm director of the North Carolina Center on the Workforce for Health, which is housed out of NCAHEC's program office. So I get to spend a lot of time with Hugh. And I just, prior to this, was working with Stephanie in the Pandemic Recovery Office for a little over 3.5 years. So excited to be with friends and colleagues here. I'll share more about what the Center on the Workforce for Health is doing, why we're here, what we're doing in terms of engagement in oral health. But for now, I guess I'll share my fun fact. don't want to steal any. I also did a cappella in college, Hugh. We haven't talked about that. But otherwise, I have a dog and 2 cats. And so I am covered in animal fur pretty much anywhere you see me. So that is, I don't know if that's a fun fact, but it's true. It's a true fact. And I'll hand it over to Melissa.
Hey there. Thank you, Andy. It's a pleasure to be here. I'm Melissa Smith. I'm the Senior State Director for Health Science Programs for the North Carolina Community College System. And what that means is I help support all 58 community colleges and their health programs in the state. And that includes workforce development, making sure that the high standards of health programs are upheld, and also providing assistance with funding and looking at ways to help create more of a talent pipeline from our community colleges to industry. So, and my fun fact is I've been here since March and hit the ground running, and every meeting I'm in, I'm with Andy. So, and Andy, I have 2 dogs and 1 cat, so I hear you, but thank you. And I can't see, is Dr. Quartz next? I'll hand it to him.
Thank you. I am a pediatric dentist and chair the Council on Oral Health and Prevention for the North Carolina Dental Society. I work with Amanda Stroud at the Ashe County Public Health Department. And my focus in my late part of my life has been an advocate for oral health in children and adults that don't have it. My fun fact is in my retirement, I've returned to my childhood, and I've got a working farm in Watauga County and enjoy them every day.
Well, Dr. Quartz, I want to take a moment of personal privilege and thank you and recognize you again for the award you just got. It is so well deserved. You've been a tremendous mentor to me. Most of what I know, I've learned from you. So thank you so much for that. Thank you for the moment of personal privilege, so I could say that. We now have our panelists with a little bit of time carved out to talk about what they're doing and what is it they want you to know about what they're doing. So Stephanie, I'm going to start with you and look forward to hearing your comments.
Thank you, Hugh. So I want to talk a little bit about what has happened with the pandemic and the federal funds that we've gotten, how they have gone to healthcare. It's a little bit tougher to break out the oral healthcare part of it, but just to give you an overview of that, and then some of the remaining funds and the work to be done. So we got about $110 billion in federal funds that were infused into the state through 6 bills between 2020 and to the present. We have, as you can imagine, initially, most of those were focused on immediate relief. So there were monies that went to keep people in business. There were monies that went to hospitals and health systems and dental practices and others who were overrun with COVID patients. There were funds that went directly to individuals. So you may recall, if you were in that category, you may have gotten some pandemic relief checks. There was money for childcare, education, food, and keeping people in their homes. So that's where the initial funds went, and there was a lot around relief. We've shifted in the past, say, 2 to 3 years towards more of a recovery posture. So more of the funds then have been focused on long-term recovery, addressing the long-term impacts of the pandemic. And as it relates to oral health, of that $110 billion, there were a significant amount of funds that businesses, and including dental practices and dental suppliers and others, could apply for. And there were 607 Paycheck Protection Program loans in North Carolina that went for dental and dental equipment providers. That was about $63 million. And the vast majority, $61 million, and the vast majority of those loans were forgiven, around $60.9 million. The purpose of that program was to make sure that people could make their payroll and to continue to employ folks. As we've moved more into recovery, North Carolina has funds that have come directly to the state, and then the local governments have gotten funds that have gone directly to them. The main focus of that money now, we had coronavirus relief funds, which is about 3.3 billion that the legislature appropriated across the state. And a lot of that went to hospitals, not directly to dental providers. Some of the local governments did give money directly to businesses, of which dental providers could have applied. And then we're at 5.4 billion in state and fiscal recovery funds, and then the locals have another 3.3 billion. Most of that money is now where you're going to find some of the long-term workforce issues that we're working on. I would say what can be difficult to see how much money we have is that many state and local governments use the pandemic recovery money to offset their current budgets and then freed up that current money to put into workforce and other programs. So our legislature has put that money towards business recovery grants. So businesses that were closed during the pandemic, many of those were focused directly on hospitality and tourism, but we also had other industries and entities that were eligible to apply. And we have in probably the tens of millions for workforce development, where there's been a focus on helping with from a workforce perspective and looking at long-term development, as well as our Federal Workforce Investment Opportunity Act, or WIOA, which goes through the North Carolina Department of Commerce and goes to our local workforce boards. I would say that the problems that Connor described in dental workforce are not unique to oral health. We're seeing them not only across healthcare, but honestly across all industries. My office is part of state government. We have a 25.7% vacancy rate right now in state government. That's been pretty consistent. We're experiencing large-scale turnover. Some of our entities, state agencies like the Department of Adult Corrections, which runs all of our prisons in the state, they have a 40% vacancy rate for corrections officers. The Department of Transportation has a 30% vacancy rate in engineering and construction. And our Department of Environmental Quality, with which the legislature gave them a couple $2 billion from typically a $200 million program to expand water and sewer across the state and to address some of our long-term problems in water and sewer. They are struggling to staff up. They have been working on it and putting in a lot of hard work for the past 2.5 years, but it is still a challenge to find enough engineers, enough qualified folks who can do the work. So I'm not sure that presents this hopeful, positive view, but if misery loves company, just know that we're seeing these challenges across all industries, certainly in government, same with our local governments, high turnover, difficulty recruiting enough workers, and certainly diversity of the workforce is not reflective of our population as a whole. So we are, again, putting some substantial funds into workforce development. And I think the challenge for this group is how do you take advantage of them to focus really on oral health? Thank you, Hugh.
Thank you. And obviously you're a great wealth of information and passion and have a longstanding commitment to helping with the workforce, especially health. So thank you for that. I am going to now turn it over to my colleague, Andy, who can tell us about work that's going on in the Center on the Workforce for Health. But before I do that, Stephanie, I will send you a slide that I use that has a picture of like a driving down the street. They have a billboard. It says, "Now hiring anybody who will show up." And so as you're describing the need for workforce across the board, I think it's important to recognize that it is really across the board. So with that, thank you. And Andy, I'll turn it over to you.
Thanks, Hugh. And I think the idea of these issues being across the board is a great segue in sharing more about the Center on the Workforce for Health, which for those who aren't familiar, I don't blame you. I'm 4 months into doing this. This is a relatively new program that was first conceptualized about 3 years ago through a partnership among NCAHEC and the NC Institute of Medicine and the Shep Center to really identify a place that can coordinate and facilitate the kind of planning and implementation of coordinated policy efforts and research, data analysis that will that reflects how interconnected the health workforce is across disciplines, settings, professions, all of that. So the center has organized its work by trying to bring folks to the table through a series of quarterly, have been quarterly meetings with about 80 statewide associations, professional associations, state agencies, education partners, policy organizations, and others to really identify how can a center that helps facilitate and coordinate these efforts provide the best value collectively to a network of folks who have been trying to sort through these things for a while. We are not, these issues are not new to the state. We've seen health workforce shortages ebb and flow for a long time. What we've seen generally is, despite really great, well-intentioned efforts to address parts of those health workforce shortages, they have tended to be siloed or in some way fragmented or under-resourced. And we've seen that we make some progress here, but we haven't seen kind of the shared collective progress that we need to really advance the health of North Carolina. So the Center on the Workforce for Health now is building capacity to ensure that across health disciplines, settings, geography, all of that, that we have a place that is connecting the best ideas to the places where action can really take place, that we are understanding the best data resources available and working with the Shep Center, LEAD over at NC Commerce and other resources so that we are connecting the best data to people who can do stuff with it. And also understanding where the gaps and limitations of our current data infrastructure to advance that as a resource collectively. And then really thinking about identifying policy resources and opportunities to intervene in a variety of settings. So the two initiatives that I'm very lucky to have inherited when I started this work a few months ago are the center's role of facilitating the North Carolina Caregiving Workforce Strategic Leadership Council, which is co-convened by DHHS and NC Commerce, that really focuses on how can the state government and state agencies better coordinate efforts in critical health workforce areas. Right now, it's focused on behavioral health, direct care, and behavioral health, direct care, and nursing. And I think points to a really important model for collaboration in state government to address our long-term needs and opportunity to engage on issues like oral health in the future. Where there's a lot of really exciting action right now is through the Health Town Alliance, which is a partnership between the Center on the Workforce for Health, the regional AHEX, and the North Carolina Chamber of Commerce Foundation to deploy a nationally developed model called talent pipeline management, which is basically taking principles from supply chain management and applying that to the messy work of workforce development and talent development. And what has been really exciting is that we are putting health employers at the center of identifying and defining what the problems are, and then facilitating collaboration regionally among health employers and educators to work together on solutions. We've collected data from over 220 health employers around the state, which collectively represent somewhere in the ballpark of 1,000 facilities, and that includes really across the board different health practices, and including oral health, and I think offers an opportunity for us to apply these kinds of models to how we can engage and address the regional challenges that are unique to oral health and then also make sure we are recognizing the interconnectivity among oral health and other health settings, and how we are better building up the workforce needed for all of us. So I'll stop there. Those are some of the highlights. I think there's a lot of really great work underway and a lot more to be done. This is a long marathon that we're running. It is not a short-term sprint. And so we are excited to work with all of you to build up the needed infrastructure that is going to support the long-term workforce development for the state, including in oral health, and recognizing this is an ecosystem, and we need to kind of figure out how we do all this, walk and chew gum at the same time as we tackle these issues. Thanks, Hugh.
Thanks, Andy. And thank you for leaning into all this hard work. I'm really grateful. You mentioned the importance of partners and organizations that are doing really great work. And that's a natural transition to Melissa and the community colleges, and just what a wonderful asset the community college system is for our state. So Melissa, I'll turn it over to you.
Thank you. I've got a lot of positive things that we're doing. Like I said, I started in March in this role, and quickly found a lot of friends in our external partners and industry that we are working together with to do some great initiatives. Andy mentioned several of those. But just to give you a little bit of just what we're doing as far as educating the dental hygienists and dental assistants in the state. Right, currently there's 13 dental hygiene programs in the state of North Carolina in the community college system, and there are 19 DA2 CODA accredited dental assisting programs, and those are all over the state. And then we also have 3 pathways that are offered for DA1 through continuing education. So those are currently operating programs. But in 2022, the North Carolina General Assembly provided monies to the community college system to disperse grants to community colleges for the startup and expansion of healthcare programs, where each of the 58 community colleges works independently. You know, they have their own budgets depending on their enrollment and some other factors. So sometimes there is a need in the community, but there just is not enough money for the equipment and for the faculty, professional development, all the accreditation costs. So this was really a way to give these colleges a leg up and to help them to give the resources that they are able to then create and expand existing programs. And so I've been doing a lot of work with technical assistants, helping people identify needs, helping them find grants, and hearing a lot of great stories across the state. Thus far, and when the budget is passed, we will have dispersed just for oral care for dental programs in the community college system, $4 million. And that includes, and I want to make sure I get all these right, the expansion of dental assisting at 2 colleges, startup dental assisting at 5 colleges, and startup of dental hygiene programs at 2 colleges. And all of these are going to be rolling out between now and fall of 2025. And so, like I said, approximately $4 million once the state budget is passed. And we have already allotted a lot of that money. So we'll be coming through here. We're also seeing colleges just applying without these funds to start new programs, and in different ways, which is really interesting. One college is their dental hygiene program will be an evening program. So they have people that are dental assistants or working that they want to do a second career, that they're able to come in the evening. And because space is a lot of an issue, those are some of the problems, if we think about, or the concerns, is having adequate space. Accredited programs, they're very structured according to how the operatories and all the equipment is set up. So they have to abide by certain rules. Simulation mannequins. I was just at Isothermal Community College and got to see the big, they have like 5 like heads that are full of teeth, and they can x-ray and work in. So those also come with a price. So it's exciting to see some of the innovations and the partnerships. Wilkes Community College has a strong partnership with their Department of Public Health, with their health department, and with dentistry, that they've actually donated some equipment that can be repurposed. as they start their new dental hygiene program. So that is the most important thing. You know, we can provide money and we can provide support, but having the partnership of our dental community, it makes all the difference. Having dentists, that retired dentists or dentists that come in part-time, you know, that's a accreditation requirement to come in and work with these hygienists and work in these labs, these working labs they have in their community colleges. Also providing support on advisory committees, or just working and having your existing hygienists and dental assistants mentor these students that are coming up. So it definitely is a very positive partnership. We have a lot of support, but we can always use more. So I appreciate having the time to tell you some of the good things that we're doing, and appreciate your community colleges and give them a little bit of love. So thank you.
Melissa, I think that a lot of folks are trying to give the community colleges love. As a matter of fact, there's a question here about what are the number of new programs? Somebody's trying to write it all down but missed. So like there's a lot of interest in these new programs, and if you could provide those numbers, I think that'd be great.
Sure, and I probably did go through those pretty quick, and I would love to. I captured a picture of the of Connor's map. I'd like to lay those over top of the programs that we have to kind of see if the shortage area aligns with where we have programs. So that'll be just can't wait to dive into that. But like I was saying, there's 13 existing dental hygiene programs and 19 dental assisting DA2 programs, and then 3 dental assisting or DA1 through continuing education, and that's with a NELDA certification. And then we have so far paid for the expansion of 2 dental assisting at 2 colleges, and started up dental assisting at 5 colleges, and starting up dental hygiene at 2 other colleges. And then we already have some applications for the next round for assisting and hygiene at different colleges. And we're also working with colleges, some colleges are already doing this, a career college promise pathway where students in high school can obtain their DA1 and hopefully get folks into the workforce and then get them started on a career ladder as well.
Thank you. It's exciting information. Keep up the great work. Dr. Kortz, let me turn it over to you.
Thank you. I'm going to try to present the perspective of private practicing dentists and the Dental Society. What I can tell you is the Dental Society was very concerned post-pandemic because everybody realized the capacity to provide oral health services was diminished because of the workforce issues. In response to that, 2.5 years ago, the Dental Society developed a task force on dental teens. That task force was and is continued to be led by Dr. Martha Ann Keels, who's done a wonderful job kind of helping coordinate where we're at and where we need to go in terms of dental workforce. The charge to her committee was to increase the number of dental assistants, increase the number of hygienists, increase the number of office staff, to find ways to enhance retention of dental team members, and finally develop a high school program that could funnel dental team members into the workforce. The outcomes that Melissa talked about, I'll kind of go over a little bit in terms of the names, but you know, this Dental Society Task Force is ongoing. There are things that are going to be happening over the next year or two, and I'm going to try to give kind of a little bit of a insight into what those things may be. But the outcomes that we've already accomplished are 2 new dental assistant programs at Southwest Community College, and Alamance County working with UNC to reinstitute a dental assisting program there. 2 new hygiene programs, one that was discussed about isothermal, and one that's going to come online next year at Southwestern Community College. The high school program is something that I think is going to be very important a website has been developed by Shelley Dates of the Dental Society, and that website will kind of give information about high school programs and kind of guide people who want to talk to high school programs and you know, use that as a funnel for workforce. And, you know, I think we looked at medicine and nursing have done this successfully. And I think we're going to have an excellent program that the Dental Society will provide to high schools. Also, scholarships through the Dental Foundation have been provided. I think we had 16 scholarships in 2024. We plan to have another 16 scholarships in 2025 for certified dental assisting programs. So, you know, we can get a little bit more diversity into the workforce, people that can't normally afford those programs. Hopefully we'll be able to provide them funding, so we'll have a more diverse workforce in dentistry. Additionally, 20 stipends of $450 were made available so people could take the certified dental existing certified dental assisting examination. And, you know, I think the Dental Society will continue to do things to support building that workforce. I think not a lot of activity happened in the short session, but the Dental Society lobbying team is led by Jimmy Harold. Will end up, you know, trying to influence the General Assembly that support for the dental team should be something considered on the same line as what they've been able to do for nursing. So we're going to be actively pursuing state funding for more of those kind of programs through the General Assembly. Lastly, some other activities that Dental Society has been working on as we looked at the scope of practice and credentialing for dental assistants. I think currently dental assistants in North Carolina are not credentials. We would like to kind of move forward in the future to do that, to make them a little bit more significant part of the workforce. We've looked at expanding the scope of practice for dental assistant. Expanded function dental assistants are something other states have used to enhance the dental workforce and make providing of oral health care more efficient. And we also looked at 16W16Zs, which Hugh, you were a big part of. Thank you for that. And making them more consistent. And hopefully that will occur in this short session, but if not in the long session, and making the requirements for hygienists participating in this program pretty much comparable. As we look to the future, you know, things are happening in dentistry that we have to prepare for. One of the most important things is we know 600,000 new patients have come into the Medicaid program through Medicaid expansion. There's talk nationally about providing oral health services through Medicare. We're working real hard in North Carolina to increase Medicaid funding, to increase participation of dentists in the Medicaid program. All of this means that we're going to have a lot more beneficiaries that we're trying to provide services for. And we know the workforce is inadequate for what we're trying to do right now. So we've got a lot of work to do, and you know, looking to the future in other ways, medical management of dental caries, minimally invasive treatment of dental caries. That's all much more staff intensive. So developing a robust oral health care staff is something that's really going to be important for us to provide the oral health services to the people of North Carolina for the next decade. So I'd like to congratulate Dr. Keels one more time, because she's done an excellent job with this workforce task force. And, you know, it's going to be an important part of the future of dentistry in North Carolina. Last thing I'd like to say is, yeah, was in private practice and education most of my career, but working in a safety net clinic, the staffing workforce issues are compounded. State salaries are pretty inflexible. If you're in private practice and need a dental assistant or a hygienist, you can end up finding the resources to pay for them. If you're in a public health clinic, that's just not possible. So, you know, besides working on total workforce, we need to convince the state that dental team members need to be reimbursed at market level, because if we don't do that, our safety net programs are going to implode. Thank you for giving me the opportunity to talk, and I'll be glad to participate in any other questions. Thank you, Hugh.
Thank you, Frank. We have a couple of prepared questions. There's some questions that are already in the Q&A, and we'll have time to get to those in a bit. But Dr. Kortz, you were articulating some of the challenging issues in building the oral health workforce, but I want to put it out to the rest of the panelists. As y'all think about responding to the oral health workforce needs, what are the most challenging issues that you think of as like, what keeps you up at night when thinking about oral health workforce in particular?
I can start from the community college perspective. Is we can have all the programs that we can handle, but we need qualified faculty, and just providing an avenue for people that are in practice that have the drive and feel the calling, because it is a calling to teach any profession, but to teach in these programs. And of course, that means obtaining a bachelor's degree, and we want to make sure that the dollar cost of the degree is going to be equal to the pay they would get as a faculty member. And so just trying to find some innovative ways to allow folks who have that interest to go on a different career ladder in education, to maybe provide funding, help them to get in roles, get them mentored by other oral health educators to be able to assume those roles in these accredited schools. So that's that, and clinical space is always for every profession. Those are the two things that I think we have a lot of concerns about.
For me, the demographic trends are fairly concerning on the student side. We're seeing, even in education, and I think it's going to change over time, but the Office of State Budget and Management, the state demographer, is in our office. And we're seeing a decline in enrollment in our elementary schools right now in the early grades. So we're going to have dips, valleys and peaks in terms of where we see students that are going into even, starting in kindergarten and going through. And so where for several years we had seen some of our local public schools need to increase their staffing and their facilities, now we're seeing a slight decline. And it looks like there's a little bit, again, we're going up to another peak. But I think with as far behind as we are in oral health and the competition that we're going to face from other industry sectors, trying to make sure that we're very thoughtful about how we're recruiting students, and knowing that we're going to have some demographic challenges in order to do that.
Just to add a dimension to Stephanie's observations, is this doesn't look the same everywhere. I think a lot of what Connor had shared too is something that and this is not unique to oral health, but something I spent a lot of time trying to work through is the challenges particularly facing rural communities with access to care and being able to meet the needs of with a limited kind of talent supply, especially for licensed, more higher credentialed positions, but also thinking about some of our non-licensed, non-credential parts of the workforce, and making sure we're building up the talent that we need to support our rural communities as we are undergoing kind of varied demographic shifts across the state.
Dr. Courts, anything you want to add to that? You've already articulated a bunch, but I just didn't want to leave you off the opportunity to comment.
I think, one of the things that is a real value to dental practices, and I suspect medical practices, is having team members that are part of the community. So with dental assistants and dental hygienists, trying to focus on recruiting people from the community to be part of that dental team, whether it's a dental assistant or a dental hygienist, is something that will really help in terms of the communication to the community and the participation of the community in the Oral Health Services program. So, recruiting high school students to be trained to do something in their community, I think has a lot of potential to help solve some of our problems.
Well, and to Dr. Court's point, my background's medical imaging, and there's not many people that you can identify with for certain. Everybody says I want to be a nurse because my mom was a nurse or my neighbor's a nurse or whoever's a nurse, but it is good to have those people out in front in the community and to provide that career option, because students are going to go into a pathway of what they see every day. And there's, this, the joke, everybody in the hospital is either a nurse or a doctor, but there's just this wide variety of allied health professionals. And certainly the dental workforce is one that I think if there was more awareness, that students would choose those pathways more. And I think that's on our side, on the college side, and on the professional side, absolutely.
Yeah, we had, when I worked for the Department of Commerce for a number of years in economic and workforce development, we had industry teams. And as we all know, the textile industry was quite strong in North Carolina. If you go back, we're going on a good 30 years now as we lost employment. But, in a lot of our rural communities, people would go to work in the textile mill because that's what their families did. And it was a job that gave you a decent wage and good benefits, and you may or may not need a college degree for it. And so I think that Melissa and Andy and Dr. Courts make a good point that we really have to be thinking about how we get people, how we make it clear to them that there are a lot of great jobs in healthcare, not just in the hospitals, but in oral healthcare that provide good wages that you can stay in your rural community where you grew up and come back and have a key part of it. But it's getting that message across. And I don't know how for so many years the textiles and furniture industries and apparel industries did such a good job of recruiting kids, but I think we need to figure out and steal from their model because that really, I think, makes a difference.
I think also apprenticeships, we're really just now taking manufacturing's cue and using the apprenticeship model in healthcare education. And this is a fantastic way for incumbent workers to move up, to get in those high school students that do pre-apprenticeships in dentistry, that then when they do their apprenticeships, their tuition's paid for. There's a lot of great opportunities out there now. It's just a matter of, and I think Andy's group's doing a great job with that, of kind of connecting the dots and putting the right people together to be able to see, we've got this need, well, we're looking at this, and help those folks work together. So a lot of opportunities. It's just getting all the right people together.
One of the questions that we thought about as we were planning for this is, how do oral health professionals engage in workforce initiatives in our state? And we've talked about a couple of them in terms of increasing awareness and others, but let's unpack that a little bit further, because like to I think, Melissa, your point, like if people are hearing about oral health, or maybe it was Stephanie, I can't remember, about opportunities in oral health, like they're more likely to pursue that. And we know that's one. But let's talk more about other ways that our professionals and the participants on this webinar today can engage in addressing these issues.
Well, I definitely think, let me just tell you all about an initiative that the Department of Commerce has. It's called Reality Check. And it is a website that they set up that they modeled from Texas, I think, where students are able to go online and you pick all the things that you want to have. So I want to have a house, I want to have cell phone, I want to have a car. And it's pretty sophisticated in terms of what it requires you to do or lets you pick. And then, it says how much you want to save per month. And then it says, okay, in order to do all these things, this is how much money you have to earn. And it's customized to North Carolina. I don't know how customized it is to different regions of North Carolina. It's probably not at the county level, but it's probably at the regional level in terms of cost of living. And then it says, okay, these are the jobs that would actually meet your need. And here's the education that you would have to have in order to get one of those jobs. And so I don't know how many schools use it. I know there's been a push for them to use it, but I think having those conversations, and then if you're a high school student, the next step would be, do I know somebody? Like, so say if that comes up as dentist, or dental hygienist, do I know somebody that does that job? Do I feel comfortable talking to them or reaching out to them? And so I do think there's that, going back to the component of it, that would be another way to reach out, is, doing that reality check, being available, talking to high school guidance counselors as they kind of move into this area of what's next for you. Because, I think there's a lot more focus these days. I confess, I have two rising high school seniors. There's a lot more focus these days on what you may want to do other than a four-year school. And so there's a lot more opportunities, I think, for kids now than there were, like, say, when I was in high school, to go to your community college, to get a partial degree, to get credit for community college classes and college classes, and other opportunities for you for work. And as Melissa was talking about, apprenticeships outside of what's next. So it's not that traditional, just everybody go to four-year college. And I think it would be a matter of figuring out how to plug in there.
And not just high school. I mean, we need to start in elementary school and in middle school, showing students all these different career pathways. And I see a lot of community college doing that, bringing these students in, letting them see the mannequins, letting them kind of do hands-on, because once they see that and participate in simulations, then they get excited, and it's better than just having somebody standing in front of them and telling them about it. So definitely, and lifting up the champions, the people that are working with the education partners that are helping them. So just, really highlighting these great partnerships and how they're enhancing the workforce. And one more thing is, we're talking about career ladders. Someone may start out as a assistant or a hygienist, and they think their ultimate goal might be to be a dentist. And so how can we create crosswalks and pathways that way to get folks in the educational pipeline? So all those things, I think, are some others to discuss.
There are a couple great comments in the Q&A. Let me read these out and get your reactions. They just moved. Volunteer to help the Dental Society's Dental Team Committee help us provide career day programs to high school students. We have the program package. We just need folks to go during the day to give this program about all the careers in dentistry. We have PowerPoint slides, QR codes, website with lots of great information. So anybody who wants to get involved, follow up with the Dental Society. Also got this comment: getting more public health dental hygienists into all the schools would certainly help. Over the years, staff cuts have eliminated the idea of a PHDH, public health dental hygienist, in every county. I've worked in public health since 1972, and I've had many people tell me they went into dentistry because they were exposed to the idea of a dental professional from interactions with me in schools for decades. Some have even volunteered with me after they've joined the profession. So, Dr. Quartz, that certainly aligns with a lot of the work you've been up to. So, want to just raise that up. Mountain AHEC just gathered the community college guidance counselors in the region and presented health career possibilities and the training required. Great opportunity to showcase what careers are possible. And we have demand for junior and high school career day presentations, but finding folks to help during the day is challenging. Anyone wants to help, and then there's an email. So those are just some reactions from the folks that are participating. Why don't you all talk more about those and give us your reaction and think about other things that might be helpful? Or pile on, whatever works best.
Yeah, I think the comment about hygienists in schools and hygienists being assigned to schools, just like school nurses, is something that could really move the dial and have a real systemic change on the level of oral prevention we could provide to the children of North Carolina and assure a better future. The funding for that is going to be difficult. The number of hygienists available is going to be difficult. But in terms of a future long-term goal, I think that should be one of the ones we look at carefully.
So there are a couple other questions in here that are kind of related to some of the things we've been talking about. Maybe we can turn to those for a little bit. Some of them are tending to be a little bit more specific than others, but and Melissa, some of them are directed at you. So one of the questions that I would just throw out is, would those employees working in the new programs that you've been describing qualify for public service loan forgiveness or any other kind of program like that might help you with some of the faculty challenges?
I would have to research that. I saw that question in the chat, and I actually copied it and put it in my list of things to research. But that's a great question. I'm sorry I don't have the answer right off the top of my head. So, but I think that's something that we can definitely look at.
Well, and then a related one has to do with qualified faculty and the requirement of a bachelor's degree as opposed to an associate's degree for faculty. Is that on your radar? How do you react to that? Part of the conundrum I think that we often face is, how do we expand access without affecting quality? And is that one of those metrics where there is quality associated, and or is it something that we just have assumed is quality related, right? So I'll throw that back at you.
Of course. Well, and we do have accreditation standards. So while we do have the community college has state board code in curriculum development and some, in that realm, these programs are highly regulated and accredited and very rigorous programs. That being said, there could be opportunities to look at all of these, but definitely don't want to, the academic rigor and all that goes into getting these students through these programs successfully. You don't want to discount that as well. So that's, that's kind of a two-pronged. It's like there can be opportunities, but we also still have to abide by accreditation standards.
Yeah, I see that in not just oral health, but all of the other health workforce training programs. So it's a hard balance, right? So I think one kind of potentially related is, does the recent proposed rule change regarding DA1 transitioning to DA2 by the Board of Dental Examiners affect the community college programs for all dental assistant 2 and potentially DA1 programs? Seems that the dental examiners is moving toward an on-the-job training, which may compete with the community college route.
Now, do they mean the coronal polishing rule? That's my question, because otherwise that they might respond to that. But I think, I think that's a symptom of the problem, is that we just don't have enough folks in the pipeline. So my hope is that we're creating this strong career ladder, and through starting new programs and really getting more students starting at the high school level out there and get them on that pathway. And I saw one of the chat comments was, all these students graduate with CNA. What about CDA? And I think that's absolutely a correct answer. These are opportunities. So how can we meet the needs of these practices that I'm sure nobody wants to train people on the job. I mean, I've seen it in other professions. They would much rather have them come with that knowledge already preloaded and ready to go and work ready. I think as the community college, we need to really step up, and I think we are stepping up, and I think our colleges are stepping up to provide this workforce. And again, the people who are, the possibly on the job, find apprenticeship options, find ways to get them safely and properly trained, that then they can have this career and move up the ladder.
Trying to read the rest of the comments. Great discussion. I don't see any other that are specifically targeted at the community colleges. Stephanie, I saw that you replied about the demographics, so thank you for that. One of the questions that came up relates to COVID and lessons that have been learned regarding strengthening the dental workforce and creating equitable access to care. Things like air quality practices, sick time for staff, incorporating layered mitigations, those kinds of things. And wanted to kind of raise that up. And as we're coming out of COVID, Frank, you had mentioned the idea of retention and what that means, and whether there are lessons that are learned with regard to retaining staff and patients, and how to balance that with cost considerations and some of those other, I mean, a lot of the things we're talking about have two sides to each of the opportunities, right? So what have we learned from COVID? How are we doing with retaining our staff? Because we know we can't train our way out of this. We got to retain too. What lessons are learned that you might be able to share, we might want to talk about?
I think the dentistry responded well to the COVID issues. I think there was a lot of support from the national organization. The ADA actually provided a lot of support for dental offices. I don't think there were any, reported mass transmissions of COVID through dental practices. I think, our ability to, and our understanding of infection disease control, I think, was amplified in that process. I think it's COVID has made a dental practice a safer place for employees to work and for patients to come to, because we upped our game to meet the COVID challenge. And I think that's going to be something that stays with dentistry forever. But I would say that in terms of the safety of employee and patients, we came through COVID well, and we're doing better than we ever done.
Hugh, I wanted to raise something that is a policy issue, I think, and it occurred to me because it's been suggested by the Biden administration in the last few weeks for maternal health care. And I know that we have real shortages in OBGYNs across the state. And it was certainly something that we talked about at AHEC and at the Healthcare Association with hospitals. And the idea that, as our population changes, that we have fewer people giving birth in some of these counties. And if we close down our OBGYN or our birthing centers because there are not enough patients there, I think a standard that I heard from one clinician was that you need to be delivering about 100 babies a year for it to be safe for your staff to have the practice. So one of the things that the Biden administration recently has talked about is this idea that if this initiative that would require hospital systems to meet certain maternal health care standards in order to remain in Medicare and Medicaid. And I'm not suggesting that we would necessarily do the same thing in dental care, but I do think it's an interesting approach from a policy perspective that if your population, if your demographics are shifting, particularly in North Carolina being, as most folks would say, we're the second most rural state in the country behind Texas in terms of where our population lives. I wonder if there's a lesson to be learned as we watch what happens there with maternal health care in terms of if we're not able to get enough dentists across in every county in North Carolina, is there a lesson to be learned from a policy perspective of some kind of other incentive to figure out how we collaborate, because I think that's ultimately what the Biden administration is trying to do there, is trying to get hospitals to collaborate on maternal care so that you would, if you can't get enough volume in your individual counties, you do it on a regional basis. So I don't know if that's something worth considering, but it's something that's come up in the last couple of weeks.
So I know that Steve and others from the Oral Health Collaborative are on, and they may be in a better position to consider that. So I don't have a response except to say thank you for the really, great observation that we can learn from others and figure out what may or may not make sense. So I think that's a great observation. So one of the other things that got brought up and that might be related to that is this notion of dental teams and how to maximize dental teams. And I don't see where that question went. But one of the, so the IOM task force report that just came out mentioned the need to explore what the opportunity might be for integrating dental therapists into the dentist-led team in North Carolina. What types of exploration is happening or could be happening to consider new types of providers who could potentially fill some of the statewide access gaps? Or I would kind of tweak that a little bit to say, and other ways of ensuring that we are best deploying scarce personnel.
Hugh, I think looking at dental therapists, and we had the discussion at NCIM task force. It's still early in the process. I think states like Vermont have spent tens of millions of dollars and still don't have a program. I think Minnesota's federal numbers for indigent care, even though they've instituted dental therapy there, the federal numbers for child Medicaid services provided have decreased since they instituted dental therapy. I think the central question is, do we need more capacity for oral health care? And the answer is absolutely yes. I would like to see studies and direction to decide whether that capacity can be provided by more dentists or adding dental therapists. It's given the situation we're in our educational systems, it's really hard to get dental faculty to provide the educational services. And I think the big problem in Vermont and why their effort has imploded is they can't get the faculty to provide the educational services. We need more capacity, but let's find out the most efficient, cost-effective way to get that capacity. And I'm not sure dental therapy is the answer.
Yeah, that's why I kind of reframed the question, because I thought that might be your take. Because I was on the task force where we were talking about that, and just wanted to raise up this notion of learning from other states. And sometimes that's positive, and sometimes it's instructive, and sometimes you learn from what works and what doesn't work. But I do think that this notion of we have need for more capacity, looking innovatively at how we meet that capacity is going to be really, really important. And Stephanie, that's what made me think about that question, is like, what kind of incentives can we provide to drive innovation? What kind of incentives can we put in to drive collaboration, to drive efficiency and alignment wherever possible? So that was the tie-in. So I wanted to make sure that was clear. And one of the other questions that's in there, Melissa, is how do we increase pay for faculty? We know that that's a critically important issue, and you've gotten folks that are eager to try to figure out how they might be able to help. So just know that that's out there as an observation and an offer to support.
Awesome. And then there's been retention money, along with the nursing faculty have received specific raises that came through the General Assembly, but there's also retention money that each college has. And at the college I previously served at, I know that was dispersed among all faculty in healthcare to raise up those salaries. So those are, maybe not consistent supplies of money, but at least that is getting some folks up, because there is a discrepancy from practice to education in the community college system. So I think that does help.
Well, Andy, I got a comment for you, and that is alignment of course requirements in a ladder-like sequence would be helpful. For example, the prerequisites between dental hygienists and dentists are not necessarily aligned. Do you see that as something that the center might be thinking about in terms of coordinating the work that's already going on, but helping to maintain focus and drive that?
Yeah, and I think just to add on to some of the conversation you were just leading in terms of innovation and finding, opportunities for collaboration, which I think getting at this question is really comes down to identifying the specific needs and opportunities, really getting started at more of a local and regional level, and finding opportunities to drive that innovation so that we can share best practices statewide and then scale good things that may be applicable elsewhere. But one of the main vehicles that I think that we're seeing successful at this stage, at least, is really looking at the talent pipeline management framework. I don't know that it is entirely I think there's some adaptations we have to make as we think about applicability in oral health and other settings outside of really where the focus has been thus far is in nursing and more like primary kind of care settings. But I think this idea of getting really specific about the needs, improving the data that are available to help define priorities, and bringing together the right employers and stakeholders to come to agreement on what the priority needs to be, and work together to find those solutions, like better aligning pathways, better resourcing your local community college to pay their faculty members in a way that'll retain the talent needed to do the training. Like all of that, I think is present in the talent pipeline management framework. Again, I think it needs to be kind of adapted and applied. I think one of the lessons that we've learned so far through Health Talent Alliance is getting good data representation from your smaller, like mom and pop kind of operations is a challenge, as opposed to larger employers that can share, that have capacity to share more of their data. But and certainly in oral health, we see a lot more of the smaller individual practices. So I think that's something that we can work on, but at least in concept, I think it provides a framework through which we can facilitate these important conversations and identify the innovations that will hopefully move the ball forward, and we can learn from and scale and all that kind of stuff.
Well, thank you. So Steve and Crystal, I think we're just about at time for us to turn it back over to you. I want to thank the wonderful panelists for their insights, their passion, and importantly, the work that they are doing and have done to advance oral health in North Carolina. As much opportunity as we have, we wouldn't be anywhere close to where we are without your great commitment. So thank you so much for that. And I also want to thank the Oral Health Collaborative for pulling us all together. Persisting and focusing on oral health is critically important, and we won't do it without you. And thank you for giving us a framework to do it. So thank you. Can we give a virtual round of applause to the panelists?
Yeah, absolutely. Yeah. Thank you, Hugh, and thank you to all the speakers on the panel this morning. That's a lot of good information for us to be considering. Really appreciate that. I was trying to figure out how to summarize some of what we heard this morning, and I'll take a first shot at it, but I would love for others to join in, particularly Crystal and any of the panel members. But I thought it was useful, very useful to hear from the Shep Center. Thank you, Connor. It's nice to have real data to back up what we are feeling in terms of how workforce issues are impacting oral health. And while we have made improvements, we still a lot of room for more improvements with where the capacity of our workforce and the distribution of our workforce and the diversity of our workforce if we're really going to take care of all North Carolinians. So that was helpful to me. It kind of gave us a grounding about that. I heard quite a bit about the need for faculty, that one rate limiting step is to get qualified faculty to be able to teach new students interested in our careers in oral health. And I didn't hear a whole lot about what that looks like. How do we increase that? How do we, I don't think it's building a sustainable system if we're depending on volunteers, retired professionals to do that. I mean, I love having those, and we certainly don't want to turn that away, but that's not going to ultimately be a system that's very sustainable if we have to depend on volunteer efforts around that. So I'd be curious if there's other thoughts of specific steps we can take around increasing the faculty. I also heard the need for clinical space, and I'll just share with you our own real life example at the Collaborative. We were looking to sponsor a medical emergencies course that is required for hygienists under the revised 16W and 16Z to be able to work in safety net public health settings without the direct supervision of the dentist there, which was a big advancement for dentistry in North Carolina. But there's a 6-hour medical emergencies course that's required before those hygienists can do that. And we were hearing that there weren't enough course offerings for hygienists that wanted to do that. We ended up finding a space at Alamance Community College. Thank you, Melissa, and your colleagues. But the space was actually very limited there too, so we could only accept 15 of these students for that important coursework. So I think some creative thinking around how we use clinical space, maybe use it in off hours or at different times that's sitting there unused, some way of building our clinical space capacity. I loved under the pipeline career ladder heading that Stephanie's comment about reality check, that we get that kind of information out early for young people who are trying to figure out their career path, know what they want ultimately, but having a tool that really helps them see, well, if you want that, you got to have this kind of education, you got to have this kind of training, you got to have this kind of income to get you where you want to do. I thought that was very useful. Thank you, Stephanie. And then I heard a lot more about the pipeline and the career ladders, and my question is, how do we make those more attractive to young people looking toward the future of professions? There's an awful lot of attention and reward, I think, for some of the young people in more of the high tech and information technology kinds of careers that look very promising to them, and maybe not as much for some of the day-to-day working in a dental office with the dental team. So I think those were just a couple of the highlights I heard. Crystal, did you hear anything you want to call out in particular?
Yes, well, I would just like to highlight that, a lot of times we don't hear what everyone is doing on a state level. And while we have a diverse group of panelists today, every one of those areas of the state are actually working on oral health workforce in indirect and direct ways. Some of the things that I felt like highlighting from today's discussion is, we always talk about the medical workforce. And we also, whenever we talk about that medical workforce, we need to include oral health. I know we seem to always be carved out, but we are part of that whole person health. So while everyone is thinking about medical and what to do about the medical workforce, please don't forget oral health. I think it's also nice to highlight that there's opportunities for people to be involved. I know in the question and answer section, Dr. Martha Ann Keels mentioned that, there's opportunities to work with her committee to actually go into the school settings for career days, or go into the schools for career days and educate individuals, educate our students and the pipeline about oral health care or oral health opportunities, workforce opportunities. Just understanding that while we're in the dental offices, the oral health providers that are working day in, day out, they're struggling for workforce, understanding that, there is a lot going on in our state. So maybe not silo yourself, but try to get involved on some of these state level initiatives. Reach out to us if you're willing to help serve and help the workforce issues progress in North Carolina. And then I also want to highlight the workforce scope of practice. I know dental therapy was mentioned, but is that a solution, or would that cause other issues? Do we need to streamline and improve the scope of practice for dental assistants and dental hygienists before adding another team member to the mix? I think that sometimes that could complicate things. While I wouldn't say, it isn't something that we would want to see in the future, many, many years down the road, I don't think this is the right time to do that until we make sure that dental hygienists and dental assistants are able to offer the care to the top of their scope of practice. So I think, those are the things that I feel like that should be highlighted, and understanding that there's a lot of people working on these issues and there is opportunities to be involved.
Thank you, Crystal. And before we wrap up, I would just kick it back to any of the panelists and speakers. Did you hear something particularly interesting or new, or something you weren't aware of before today that you would like to raise up today?
I think just to a point that was talked about, that there's, clinical space, and that there's often maybe unused space in offices. Well, there's also a lot of unused space in these fully functioning dental labs that all the community colleges are required to have, with these dental hygiene programs. They have these operatories, and that could even be an opportunity for public health dentistry that there's just so many opportunities for partnerships that state is giving all this money for equipment, and we have this equipment, and a lot of it's top of the line equipment because we want to align with industry. But there are so many opportunities to work together with the community college system and with industry and with government services to provide access. I saw a lot about access to folks. These are excellent times to be thinking about all these opportunities and how that might work in the community.
Hey, this is Hugh. One of the things that I've been thinking about is this notion of whole person health, and the mouth is part of the body. And historically, we haven't necessarily done a good job of having whole person health that includes oral health, and that dealing with those broader dynamics will help with all of the workforce, because people will be more interested, people will be more aware, all of those kinds of things. And so as we are looking at kind of the AHEC mission, which is recruit, train, and retain the workforce, part of that is how do we make sure people are more aware, and really look forward to working with you guys to continue to enhance that awareness. And I also think that Crystal, to your point, like the more we make this is just part of healthcare. And the more we can integrate oral health into overall well-being, the better we'll be able, not just at producing health, but also at encouraging people to pursue this as a workforce opportunity.
Thank you. So I want to again thank our moderator and our speakers and also the whole collaborative team that helped us put today's webinar together. I'd be remiss if I didn't thank our funders, primarily Blue Cross Blue Shield Foundation of North Carolina and the Duke Endowment, for enabling us to do the work that the collaborative does. So thank you to all those folks. Next slide, please, Brady. An opportunity that's coming up for oral health people to get more involved is our annual Bernstein event. Some of you are familiar with the Bernstein Fellows Program. And then once a year, we have a grand event where we bring together fellows, people in the industry, health colleagues, particularly rural health focused. And it's a really great time to network and to mingle and to catch up with old friends. So if you haven't been before, I think you would find it wonderful. And it will be held again this year on October 2nd at the Friday Center in Chapel Hill. Next slide. So thank you all for attending. We will be following up with the attendees who gave us their contact information with a short evaluation of the session. I think I saw a question in the one of the questions in the chat about could they get the contact information for our speakers, and we will do that for you when we send out the evaluation. But thank you all for being here today, and we look forward to more oral health days in the future. Thank you all very much.